21 basically is actually from View, which is one of the UCLA-affiliated county hospitals here. They got a guy there, Dave Talon, who's kind of like the infectious disease guru of emergency medicine, and he started this ID Net, which is a bunch of hospitals where they pool data on ER-related things.
No. Better? I didn't even say anything.
Houston,
nose off.
Houston, we have, yes.
So it basically looks at patients' expectation with regards to getting antibiotics in association with simple lacerations. And one survey they said found that 40% of emergency physicians reported use of antibiotic prophylaxis for at least a quarter of their non-infected wounds. I guess we're all into occasionally giving antibiotics in the hopes that this will prevent a wound from being infected, particularly if it's maybe a wound in a certain spot or if it's a dog or something like that. Anyway, they examined the use of antibiotics in 260 patients with uncomplicated lacerations. The patients were interviewed before and after they were seen to ascertain their expectations. Antibiotic treatment was documented in 1 in 5 patients. Variables associated with the use of antibiotics were wounds that were more than 8 hours old. That's one of the kind of things that is a piece of baggage that we've been carrying around a long time, that there's some golden period, and beyond which that golden period exists, you should not be closing those wounds. And when you actually look at the literature on it, they can't find one. They honestly can't find one. And in fact, we did a study not that long ago that specifically was looking at it, and again, they couldn't find one. Anyway, puncture wounds got antibiotics more frequently than not. It would be great if we had some studies on puncture wounds. There are virtually no studies on treating puncture wounds. I mean, I go through it, I'm looking for it, nothing. Those involving skin or subcutaneous fat amputations, I don't know why that would get you antibiotics. And lack of insurance, maybe that's in the hopes that this person won't get into trouble because they may not be able to get to see another doctor again. But more than half of the patients treated with antibiotics did not have any of these characteristics. A third of the patients indicated that they expected to receive antibiotics, but most of the patients, 3/4, no longer felt that way after the physician encounter. So I think the two messages here is that a substantial subset, for some reason, think they're going to get antibiotics. A subset do get antibiotics, but that physicians are pretty effective in saying, in preempting them and suggesting why they don't, and they're okay with it. I think that there are a lot of things that we do in medicine where we can do what a friend of mine calls the preemptive strike. And the best example of a preemptive strike would be, a kid who has a fractured clavicle, and you don't use a figure of 8. You just put them in a sling, and they go to their family doctor or the orthopedist, and they said, "What's this? You're in a sling? Where's the figure of 8 dressing?" Well, the way you preempt any criticism of your work is to say, a lot of old-fashioned doctors who haven't read literature in about 50 years still believe a figure 8 is important in the management of clavicle fractures. So if you have a doctor who says anything about the word figure of 8, just leave the building immediately because that. So that's the idea of a preemptive strike. When you think that somebody's going to criticize your work, you just attack first.
Abstract 22 is one of 3 in a row that deal with tranexamic acid, which is, ever since Crash 2 hit this sort of news, it's been out there. The idea that tranexamic acid, which is a drug that breaks down, that blocks your ability to break down clot. It's an anti-fibrinolytic drug. It's relatively inexpensive. Oral courses are as much as $170, but it's nowhere near the sort of $2,500 to $5,000 range for some of the other agents like activated factor 7A that got thrown out there. This looked at using a subset of the Crash 2 data to look at whether tranexamic acid, this antifibrinolytic drug, has any utility in people with traumatic brain injuries. So it was looking basically at people with trauma, particularly people with head trauma. And they took people with a GCS of 14 or less that all had a positive head CT, And they went into looked at what happened if they gave them tranexamic acid. And they found it first, and the dose is pretty quick, it's pretty easy. Basically give a gram load, and you can give them a gram over 8 hours. And what they found in this particular thing is several things that I want you to think about what you as a practitioner think of this information. They found a lower volume of hemorrhage. They found less likelihood to have a significant growth of the hemorrhage. They found that they were less likely to have new areas of bleed, less likely to have mass effect. Do you care about those? Why not? Excellent. So you want to know what that means to the patient. Did it change anything for the patient? And they did that subset as well. So those things are called DOEs, the disease-oriented stuff. It has just to do with the disease. I can measure the disease. There's also patient-oriented outcomes, which anytime you look at a study, it's worth looking at what are they measuring here? Is it something that really makes a clinical difference to either me or the patient? And if not, I'm not sure I care. So they did do the extra step, and they said mortality was less, the risk of dependence, needing somebody to take care of you was less, and then there's this thing called a composite where they throw in a bunch of truly patient-oriented outcomes, they put them in a pot and see if overall it's less. And they found that tranexamic acid was helpful. And their conclusion was it needs further study, but it seems to improve outcome, which to be honest was a very legitimate way of not saying, oh, it's the best thing since sliced bread, but it looks like this may have some promise. What's interesting is that this sort of hasn't been uniformly adopted out there. They have a major big trauma center up where they work. Ours is a decent-sized trauma center, and our surgeons were all over this tranexamic acid for a while. And now we only have a couple of proponents of this, and it isn't used routinely. And I'm not exactly sure where we stand with tranexamic acid in trauma. It's cheap. It seems to have some effect. CRASH 2 has a lot of detractors of the study because there were some issues on how it was done. But it's a potential, and it's so far. Did any of you guys use tranexamic acid in trauma? Any of you guys use it? You do. Are you in a trauma center? Yes. And is it routinely done or selectively done? No, it's selectively done. Okay, and what selection? How do they pick?
Whoever's on the service.
Yeah, exactly. Exactly. That's what ours is too. So yours is selectively done based on who your trauma surgeon is that day. Oh. Got it. So
what do you guys do?
We had a lot of enthusiasm when CRASH 2 was first published, and then that enthusiasm pretty quickly dwindled. I think mainly because there were a series of studies that came out after CRASH 2. So CRASH 2 was the big positive study, but then there was always one big criticism of CRASH 2 was, okay, it decreased mortality. And we know that tranexamic acid is an antifibrinolytic, so the way it should have decreased mortality is decreased blood loss. I mean, that only makes sense. But when you look at the two groups in CRASH 2, they basically had the same amount of blood loss. So then they said, okay, well, that's strange. Well, tranexamic acid does other things. It's also an anti-inflammatory drug. So maybe it's the anti-inflammatory effect of tranexamic acid that had the benefit in mortality. So then they started chopping up the original patients into little subsets. And when they looked at the patients who got tranexamic acid in less than 3 hours, their mortality went down relative to the controls. And when they looked at those that got tranexamic acid greater than 3 hours outside of their trauma, their mortality was significantly higher. So then the water got very, very muddy, and even our trauma surgeons were like, okay, wait, even though this seemed like a good, cheap drug at the beginning, now it seems very confusing, and you can think of all kinds of confounders as to why that might be true, right? Maybe the patients who got tranexamic acid in less than 3 hours maybe had nothing to do with the tranexamic acid, why their mortality was less. Maybe it's because that was just an on-it trauma center. They were getting everything done. They were getting it done quickly. They got them enrolled in the study quickly. They had all the right people there. And the people who got it in 8 hours, maybe it was just kind of a slower pace. They couldn't mobilize resources. So I think that second study, at least for us, really muddied the waters, and now it's not used essentially at all. Maybe as a last-ditch effort and kind of a dying patient in the department. But the whole CRASH 2 thing got messy. Looked clean, and then it got messy.
And
it was a British study. I was with the British in Afghanistan, British Field Hospital. Give it to everybody.
So you were. It's a British study, and you were at a British field hospital and gave it to everyone.
They want to give it to everybody. So Medicaid patients blown up to everybody.
And outcome-wise,
Who knows?
no.
Yeah, right.
One of
I mean, even CRASH 2 is 1%.
One of the things that was even from the original study, which was considered positive, was the numbers needed to treat to get these outcomes were surprisingly. They said, well, I think one of them was mortality was like number needed to treat was 64, and and bleeding death was the number needed to treat was 125. So it wasn't by any stretch of the imagination a miracle drug, and it was cheap, and the consensus was it's cheap and it may help and use it. But then I guess if you start getting into these other more carefully looked at issues about the whens of getting it, maybe it even diluted these numbers even further.
Yeah, I think the next abstract, like I said, the next three are kind of all in a row. This is high-dose tranexamic acid reduces blood loss in postpartum hemorrhage. This seems like a title that kind of says it all. You know, you gave them high-dose tranexamic acid. What do you think happened to the patients? Reduced blood loss, I guess. That's what it's telling me. This is an open-label trial, so this is non-blinded. So the physicians knew exactly which patients were getting the tranexamic acid and which ones weren't. And they got a big dose, unlike CRASH 2 with the 1 gram. They got 4 grams of tranexamic acid. And they said, hey, we had a big positive result. It was great. It was a good positive study. They really did try to claim it's the best thing since sliced bread, like Diane said. And when you actually look at the numbers, so the blood loss in the tranexamic acid group was 170 mLs, and in the control group, it was 220 mLs, right? So 50 cc difference in blood loss, which in my mind isn't that significant, although somehow they calculated a significant p-value, good for them. And then when you look at some other stuff, you know, transfusion requirements and overall outcome mortality and things like that, there were absolutely no differences. And so this is a study with a very subjective primary outcome of estimating blood loss in physicians who knew if the patient got the study drug or not and ended up seeing a 50 cc less. This isn't really getting me all too excited. I get it. Like Diane said, it's cheap, but I still am not sensing this big improvement in patient-oriented outcomes. But I do see us starting to think about using this for, like you said, almost everything, you know, just every indication, because what could go wrong? But the what could go wrong is this is an antifibrinolytic. So theoretically, you could have increased clotting. There's just no question about that. You could have more DVTs. You could have more PEs. And most of these studies are pretty small, 154 patients. But you know, there's 1 DVT in the control group and 2 in the tranexamic acid group. I don't know what to make out of that. These are small numbers, but know that it's not a benign drug. Every drug carries some risk, and the risk of this one is the exact opposite of what you want, which would be an inadvertent clot.
The last abstract on this topic is actually about women with menorrhagia, so not severe bleeding like the postpartum hemorrhage, etc. But it's a thought piece from a pharmacist who says that tranexamic acid has good rationale for working, and that when we review the literature, there's evidence that it reduces menorrhagia by about half in the average woman who's treated with it. Well, the advantage of this drug over the traditional treatment for menorrhagia, which would be oral contraceptives, is it preserves fertility. So they then go through a whole literature review where they cite some of the stuff that Sanjay was talking about, which includes that the risk of venous thromboembolism is not insignificant in tranexamic acid, although the estimates are difficult. They challenge that by saying that is also true of OCPs. And interestingly, they've ultimately come up with the conclusion that for women with menorrhagia who desire fertility protection during their menorrhagic episodes, that tranexamic acid may be a viable alternative. And I don't know if anyone's doing that, but apparently it's been used safely for many, many decades, actually, and it's over the counter in Britain. So, you know, it's one of these things. I think in this particular context, it may be a little bit safer, because the risk profile of OCPs may compare negatively compared to tranexamic acid, whereas in a patient with significant bleeding from trauma, the risk profile may not be so good. So anyway, just more food for thought. I don't think that the preponderance of evidence for this drug has us throwing it out yet, but I certainly don't think that the bulk of evidence suggests that we should be really adopting this into our practice yet either. So I think unfortunately the jury's still out on this one, and there's reason for optimism, but there's still considerable skepticism.
Moving on to a different topic now, it's the UTIs and kiddies topic. And the issue is that are these UTIs resulting in chronic kidney disease in children, since we seem to have been missing them for many, many decades while we were so focused on occult bacteremia and pneumococcal sepsis and measuring white counts. And now that we got over that, we had to come up with a new way to analyze kids who had source unknown fevers, and it was now the urine. And so this paper says that it's been reported that 2 to 5% of children will experience one urinary tract infection before puberty. Well, that doesn't sound like a heck of a lot, to tell you the truth, and you really need to be careful about how you define a UTI. A UTI is just not bacteria in the urine, and it's not just 50,000 colonies. It's about, you need to have pyuria as well. You need to have evidence of an infection rather than just kind of like resident bacteria there. But in any case, these guys try to ascertain what was the link between chronic kidney disease and UTIs, and so they did a literature review of 10 articles looking at 1,500 kids involving tertiary care center cases. So this is already a selection bias kind of thing. And these papers suggested that childhood UTIs appear to be associated with a possible cause of chronic kidney disease in 0.2%. That's 2 per 1,000, 1 per 500. That might be, 1 per 500 might be a significant number, though, if there were bajillions of kids having UTIs. Then they looked at their own experience at their own center, 58 kids who had chronic kidney disease. 13 of them had a history of symptomatic childhood UTIs, and the rest didn't. They had glomerulonephritis or diabetes or something like that. So of those 13 that had UTIs, they had evidence of structural abnormalities on their initial kidney exams, but they didn't consider vesicoureteral reflux as, which existed in 3 cases, as a significant structural abnormality. So they said, using their calculations and their best estimate, they said that the etiologic fraction of recurrent UTIs causing chronic kidney disease could not or would not exceed 0.3%, which is 3 in 1,000, 1 in 330 cases. Now, I don't know if that's small or large, but my contention is that many of the kids that we diagnose with urinary tract infections really don't have them. And the ideal study would be to take a whole bunch of kids who are about to have surgery to have their tonsils taken out or something else selectively done, and cath every one of them and see what grows. And do it for 1,000 kids or 500 kids and see what the baseline rate of asymptomatic bacteriuria is in children. And I'm surprised, unless it's been done and I've missed it, why that hasn't been done yet, because that would really help us answer these questions rather than fishing around for assuming, because when we say a kid has a fever and the cause is an infection in the urine, we're talking about pyelonephritis. We're not talking about a bladder infection. And so I think this is still personally very mucked up here. And I don't want to be putting catheters in all these little girls in particular when we don't really need to. And I think that we need some clarification of this.
Which isn't out there, just so you know. The AAP Guideline, we did a sort of spiel on this last year, the year before, when the new AAP UTI Guideline came out. It's wacky. And it's really wacky. They reintroduced the concept of suprapubic aspiration. We used to do that to kids 30 years ago, stick a needle in their bladder. I mean, my God, seriously? To chase something that's not clear how we've gotten so far afield in making the diagnosis. Kids have seven febrile illnesses per year the first 2 years of life. So they're going to have fevers 14 times in 2 years. The definition of what truly is a urinary tract infection is all over the map. The second abstract looks at some of the problems with this. So what are the issues that come up with this? And even the guideline, if you try to follow that guideline, if you really pull it out and you really try to follow it, it is crazy. It brings in the race, non-black children, girls, and where did that? It's pulled from literature, which tells you that the literature is wacky in and of itself. The reality is the pediatricians don't do it. They don't follow their own guideline. Do they do this on all their febrile kids? Of course they don't. Of course they don't. So this has gotten kind of crazy, and I'm a little stuck because I'm not exactly sure the best practice now. It's gotten so murky. I'd like to pick up kids that are sick. I'd love to figure out which ones really need to have a workup, but I'm not sure I can figure that out in the ER anymore. It's kind of crazy.
Well, I think for me, Abstract 25, I mean, there's two issues, right? There's how often is there asymptomatic bacteria, and if you go hunting for it in young children, how often will you find it? And when a kid happens to have a fever, are you just finding garbage? That's one thing. But I thought 25 was nice because I grew up understanding that if a kid has more than one UTI, they're supposed to get a VCUG. You know, they're supposed to get this urethrogram, and that's an invasive process, and then they're supposed to have their ureters reimplanted and all these kinds of things. And these guys come pretty firmly and say, that practice is not necessary. That if the child has recurrent UTIs, there may be the need for a structural investigation, but it can be a simple ultrasound. Just make sure they don't have a horseshoe kidney or something like that and move on. So at least there's a little bit of progress there, because that's always been my biggest problem with diagnosing UTIs in young girls is what do you do if you diagnose a UTI, and it gets back to Rick's point, if it's not a real UTI, but you make the diagnosis a couple of times associated with a fever, are they supposed to get VCUGs then? Now they're a real kidney patient. This sort of calms that down at least, although it doesn't shed light on the other problem of how often are we just picking up nothing and calling it a UTI.
Are any of you working at a pediatric ER? So I guess the issue is, what are you doing? Have you bought the line of occult urine infections, or how are you dealing with this? Anybody?
A 9-month-old girl comes in with a fever and otherwise looks well. No, fine. She's fine.
Just fever.
Just a fever. She's just red cheeks.
Yeah.
Are you getting
Tylenol.
urine? How many of you are getting urine cultures on those girls?
Got to be
Yeah,
some.
give
It
it
can't be
something.
none.
Yeah.
2 days. Yeah, you letting that's differentiating for you? Yeah, exactly. So that is probably a fairly representative answer, right?
Yeah,
There's
I
a
think
lot
so.
of variation
Huge.
that has not a whole lot to do with medical science at this point. And I don't know the right answer to this
I don't
question.
think
I don't think
anybody
anybody
does.
can, but it is. I'm not surprised that there would be significant variation.
We have like guidelines that are practical and straightforward, but evidence is not really so strong. But we're expected to do, depending on the age and on the between 3 and 36 months, depending if it's higher or lower than 39.
So yours is based on age and elevate how high the fever is.
Yes, and so there's a score to see how sick is your kid, and depending on that, you're going to decide which test you're going to do.
Right. If you actually look at the guidelines that the AAP came up with, actually they're quite complicated, and
really
so
crazy.
it's not something that you could have in your head, even in an attempt to follow what they're recommending. So I think it's a tough situation. It would be great, I must admit, and are we among friends here? That
It's being
the
recorded.
idea- the
I don't know
idea
these
of
people.
getting a the idea of getting a bagged urine, I know, and putting a dipstick in there, and there's no nitrites and no leukocyte esterase. I mean, I feel good about that. I really do. Out you go, kind of thing. I don't need to go any further, because you do need to have pyuria in this thing. And if your leukocyte esterase and nitrites are negative on a bagged urine, I feel a lot better. I don't think I have to go any further. Maybe that's just rationalizing it, but I don't know that we have to find every one of these things, because even if they must be self-limiting diseases, because
Just to make things even murkier, has anybody looked at
Right.
truly positive cath urine specimens and see, do we need to treat these children?
well, that's just it. They must be there must be self-limiting, because if we never picked these up before and they went away, it's like, and nobody's on dialysis, it's like,
We've gotten so creative with our, cath these people. There's a new article that just came out in the last month talking about ways to get urine in children, and this one has this whole protocol. You take the poor baby and you expose their genitalia, expose their genitalia, wipe it down, hold them up by the arms. Someone rubs their low back, somebody else taps over their bladder, and another person stands up with a cup.
Hey, this is a kid's show.
And they show pictures of this
Family
whole
affair
sequence
here.
of this poor child being dangled in the air with his little privates. It was it does look like a chicken. Poor thing. It's just crazy.
Actually, I'm surprised. We just did that paper in the abstracts.
About how to get the urine?
A week ago, yeah.
Pictures are
And
hilarious.
there's they made no reference to the fact that in 1986, there was an identical study where they didn't lift up the kid like a chicken, but they
Tap the bladder.
tapped over the bladder. And the ability for that to create, and then they would just catch it in a cup.
Anybody who's a boy baby
Yeah,
who's
just
changed
make
their
it
diapers
wrong.
know that. You get nailed.
All right.
The boys are easy.
They are easy.
Now, where are we at?
We've run totally off.
Are we on 26, or did you do 26 sort of?
We can do 27. We can do
good
it
one.
quick, too.
27's.
This is RCT of rapid versus 24-hour rehydration for children with acute gastroenteritis. This is definitely an important topic, rehydrating kids who come in like vomiting and diarrhea, but it is a very, 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 did I say very, very strange paper, because what they did is they took kids with moderate dehydration and they randomized them to get rehydrated over 4 hours or over 24 hours, which already seems weird. That's a pretty long time to take to rehydrate a kid who just has moderate dehydration. But they did all of their rehydration via NG tube for all these kids. So they took kids who were just a little bit more than mildly dehydrated, and they stuck an NG tube down all of them and said, either we're going to stick this down your nose for 4 hours or 24 hours and slowly pump you full of fluid. And what did they find? That kids in both groups got rehydrated just fine. 4 hours is plenty of time to rehydrate a kid. I think we already know this. What they did find, very surprisingly actually, is that the kids hated having NG tubes put in. And those who had them in for 24 hours hated them about 6 times as much as the ones who had them in for 4 hours. So that's one thing we learned, which I don't think there's a ton of learning here, but I am planning a follow-up study on adults. So if anybody would like to volunteer, there's a sign-up sheet in the back.
Well, this is from Australia, and our Australian friends would acknowledge that they routinely put down and it's like a piece of spaghetti. It's not like the kind of NG tube we're thinking about. So please help me out here. Yes? No? Come on.
It looks the
Anybody?
same or it looks different?
Help me,
Hey, don't do it.
please.
Nobody's
You
gonna do
do
this.
it. Don't a little bit.
A little bit.
Anybody?
I put it just.
There you
just
go.
this
You're
far-
on-
All right,
Just this
all
far
right.
down.
You're on an island, Rick.
No, I'm not.
In New Zealand, we do that's our first route under 2 years old in moderate dehydration. Not first route, but if they fail IRT and so
Right.
then we go NG.
But that is a
Oh.
critical point, right? Is like trying
Try
slow
first.
oral rehydration therapy with an antiemetic. And this whole theory of like, oh, we can't give these kids antiemetics, I think is completely out the window. That's gone. But you're right. As a second line, it's totally fine. But here it was used as a first line, which made it so
It's a great
strange.
teaching opportunity for the parents to teach them how to rehydrate a kid who's been vomiting. It's a wonderful way to teach them that small amounts, letting the kid get it through their pylorus and giving them another one, and rather than because the kids are thirsty and you give them a bottle and they chug the thing down and then erp it all back up again. So you have to do it little bits. It gives them something to do. You have ways of doing. You can do it with a syringe, have them use 5 cc's, then repeat that over, or just give them a popsicle. It sort of titrates itself.
American Academy of Pediatrics, World Health Organization basically said rapid rehydration, 4 to 6 hours, fill up the tank, and follow that with full age-appropriate diet because all of these kids are calorie depleted, and that one of the criticisms of American care is that kids who have mild to moderate dehydration, they're supposed to get the sippy diet, and we have a low threshold for starting IV lines in these kids, which don't need to be done. And the opportunity to show parents how they can treat these kids is obviated when they're trying to start an IV. And plus, starting the IV and the kids it doesn't always work, and then you have to stick them again, and that's not good. That's not good.
Yeah, and that time spent teaching the kid how to teaching the parents how to rehydrate the kid at home may save them a future ED visit as well. So you could have huge benefits in the long run.
And fluid, when we do give it IV, which is supposedly only in the severely dehydrated kids, is what? It's normal saline, normal saline, normal. I remember, in the old days, it was quarter, who gets quarter, a half? I never figured that stuff out. Now they get rid of that. It's all normal saline. Throw in some calories too. D5 normal saline, although there's not very much. These kids are ketotic. They need some calories.
Indeed. All right, oral hydration, wonderful. So number 28 is the measured degree of dehydration in children and adolescents with type 1 DKA. So a couple issues on here. So in kids with DKA are dehydrated, okay? And if you rehydrate them, what happens to their brains? They get better. And then, but there's a fear of them developing cerebral edema, and so there are many recommendations about being really ginger with the IV fluids. We'll get back to that. So that's sort of the backdrop of this. The authors in this particular question, for this particular study, asked two questions. They asked, the first is, in DKA, can we predict how dehydrated a child is? Just, we look at them, we say they're moderate or mild or severe. Are we accurate in any way, shape, or form? They compared their weights at the time of the assessment with when they got better, what their weight was. So they had, pretty good metrics for that. And they found that the people who were moderately dehydrated were more severely dehydrated than the mild cases, but they were also more severely dehydrated than the severe cases. So we're not good at assessing. We just said they're moderate, that was our thing. So this whole idea of going mild, moderate, severe was sort of unraveled in the setting of DK. And then the secondary question was, is the severity of dehydration associated with the severity of DKA? And that was likewise just all over the map. It didn't really relate. So, but really what this study was trying to get at is fluid resuscitation, can we predict a case like these people are severely dehydrated? We can give them a little more fluid, these ones a little less, so we can avoid this dreaded complication of cerebral edema. And I think it's worth just mentioning to everybody that that's still out there in the pediatric literature and in the pediatric endocrinology literature, that you have to give these kids like 10 cc's per kilo bolus, even if you assess them to be severely dehydrated, severe DKA, all that kind of stuff. And I think that's crazy. I think it's crazy. I think that our studies have pretty clearly shown that about 1% of severe DKA cases will end up developing cerebral edema, and that's driven by the underlying severity of their disease and not our therapy to it. I think one of the key features of treating DKA is rehydration and at least getting them to a euvolemic status, and so we should do that. If you choose to bolus them 10 cc's per kilo every 15 minutes, that's fine by me. I would do 20, but if you choose to do 20 or something, or 10 or 20, do another 10 or 20 as soon as you do the first one, and just document no urine output, child still appears dehydrated, and move forward. Once the kid's starting to make urine and stuff, let's get ginger with the fluids. But I think this idea of withholding tons of fluids in these severely dehydrated, severe DKA patients is just crazy, not supported by the large majority of the literature. Are any of you still doing that, using these tiny little droppers to rehydrate children with DKA?
I wasn't doing it, but I just got chastised by I transferred a kid to, I forget, like Ohio State or one of the big children's hospitals, and I got totally chastised by their intensive fellow
Right.
intensive about
Right.
I gave 220 per kilo boluses and then had some more fluid going.
Well,
That's classic.
And they were chastising me.
no, that's exactly.
With a CO2 of 10 or 9 or something like that.
Because I remember, even back when we were training, we both trained locally here, and we worked at Children's Hospital of Los Angeles, and they had a protocol there in place that if you had a kid with DKA, you as an ED physician could only give 20 cc's per kilo of fluids, before you had to call in the pediatric endocrinologist to sort of okay the rest.
The
So-
expert on rehydration, the pediatric endocrinologist.
Right. So it is really pervasive, this idea that we can't give them fluids, although there is no literature to support that at all. And I don't know how to change that.
And I
What'd
think-
you say to this helpful consultant?
So thanks for taking the kid.
As long as you're on your way. Sure, real back up. I just got
Yeah, I think you should be aware that that's going to happen sometimes. But it's
Yep.
no different to me than the trauma surgeon, with their random, you didn't do a rectal exam or whatever. I mean, it's like the world is changing and you're just not, the guy's just not ready for it or hasn't read that literature. And so you politely smile and say, oh, that's good. If you can get a little education in the reverse direction, great. If you can't, then you politely be happy and say, yeah, I'll consider that next time. Thanks for the information. But I think overall, you should be aware that you may get that. And if to mitigate against it, I do document, 20 cc's given, child is still lethargic, no urine output, will rebolus. And I think that then I would like to see somebody come back in my chart afterwards and say, no tears, no urine, I gave a bolus. Oh, you're a terrible doctor. Okay, well, that one I can live with pretty comfortably.
29 deals with this idea of alternating or not alternating antipyretics. So this is a brief look at 7 randomized trials of acetaminophen and ibuprofen used alone or together in febrile kids. They also reviewed 4 guidelines from AAPA and NICE and some other places regarding their recommendations. The studies involved about 1,000 kids, 6 months to 14 years of age. They were followed for 24 hours or less in 4 studies, up to 10 days in the remaining studies. And the treatment dosages were in the usual range. And basically they concluded that in terms of fever reduction, there was no benefit of combining treatment over the first 4 hours. However, after that, combined treatment did result in a statistically greater reduction in fever, which was of some marginal clinical benefit. So basically, they point out that although the people who have made recommendations about this alternating therapy say don't do it, it doesn't seem that that's really a big deal, to tell you the truth, either way. Some people say it will confuse the parents and they won't know, and that might happen too. But there's no compelling evidence to do it, and I think there's probably no compelling evidence not to do it. I think ultimately ibuprofen may work a little bit longer than acetaminophen, but they're focusing on comfort measures and not reducing fever because of this fever phobia kind of thing. And you can even take the rationale that fever is maybe a good thing and it's a physiological response to infection, and it's not necessarily a good idea to suppress it. In fact, I think there were some clinical studies where they suppressed fever and patients did worse.
You had a comment out there?
Well, that's just what I was going to ask. Why are they treating it?
Well, mostly because it just makes the kids miserable. I mean, the kids are usually, when they're having that 104 fever, they're just crying and it's driving everybody crazy. So I agree, if it's just a temperature, if the kid just has rosy cheeks and they look hot, they feel warm to the touch, probably not worth treating them. My kids aren't like that. When they get a fever, it's just a nightmare. So, and I'm a big fan of Motrin at night because it lasts a little bit longer, and that's the only reason. And otherwise, I think I really like Tylenol. So I alternate it, but only because Motrin gives me that a couple extra hours at night.
It's a great educational opportunity on multiple levels when somebody brings in a child who has a fever, to educate that it's not the temperature elevation, it's the behavior. So if you can point to the child who's just pulled the ophthalmoscope off the wall and is running around tearing apart your 4x4s and has destroyed the little exam room, that's fine behavior, temperature or not, that's fine behavior. It also is worth asking them how they're giving, what they're giving. It's not infrequent that your child grows pretty fast, and the dose may be totally different this illness than it was the last febrile illness, which may have been 6 months ago. So the dose may have changed and they may not have gotten up to speed. And what you pull out of your kitchen drawer isn't appropriate as far as how to dose. People will sometimes, I can't find the little cup, let me just grab a teaspoon. Well, your teaspoon ranges from 2.3 to 7 cc's. So you can be underdosing by half or overdosing by 20% on giving the dose. So that's another, ask them how they're giving it. And the last thing we did is we looked at our discharge instructions. And it turns out that the pre-programmed electronic health record discharge instructions that got spit out were way on the low end of the recommended dose and had to get rewritten so that they were actually appropriate dosing. It wasn't, because our instructions were underdosing. So to make sure all those pieces are in place, it's a great educational opportunity to sort of teach parents about what fevers are and how to fix it and what to do and where mistakes can get made.
I just tell them it's probably a urine infection. Will go away
Yeah.
in a couple days.
Just as long as you give them the antibiotics, none of it matters.
I like abstract number 30. It's one of my two favorite in this whole section. This one has to do with meter dose inhalers. And the concept of the paper was that we're going to look at 2,200 people or so and look at how people are using their meter dose inhalers or their dry powder inhalers. And the concept is that a dry powder inhaler it's billed as and sold as more effective because it's easier to use. You take your little thing, you click it, you inhale. Sometimes there's a little whistle that makes happen. You know you're inhaling it. It's all good. And they looked at whether people were using it right. My favorite sort of real life thing that happens with this is there's a great episode of House. You guys watch House? Anybody watch House? House is a TV show about the most dysfunctional doctor on the planet. He's drug addicted, he's acerbic, he's mean, he teaches teaches pearls in a really nasty way. It's actually, I don't watch much television, but that is a show that as a teacher has so many teachable moments on what not to do that it's a great thing to use when you teach. It's like, don't do what House just did. That's a terrible way to teach. That's a terrible way to do this. Don't say this to patients. It's wonderful. I use it all the time. There is an episode, however, which I think was the only episode where he was a reasonable human being. And it's called, Do You Think I'm an Idiot? So the episode title is called, Do You Think I'm an Idiot? You can YouTube this. It's hilarious. And it shows him in his white coat, looking very official and actually quite pleasant, sitting across from a woman who's there for her umpty bajillionth visit for asthma. And he said, well, are you using an inhaler? Yes, I am. Are you using it correctly? Do you think I'm an idiot? And instead of saying something he would usually say like, yes, I do, he said no. He said, no, just humor me. Can you show me how you use it? She takes it out of her purse. She shakes it. So far, so good. And then she goes. That is a very good example of this paper. This paper basically said, let's watch people use their meter dose inhalers and their dry powder inhalers. Let's take a peek. Let's see what happens. And it turns out that a third of people were totally wrong on how they did it. And what most people will do is take that, the biggest mistake that's usually made is they take a big breath in, they blow out and activate. So it all just goes everywhere. It doesn't go in. So you can tell people to liken back to the 60s and 70s when they really did inhale for a reason that they wanted to, and now tell them that they can inhale a drug down that's legit instead of illegitimate in these cases. But people did make a lot of mistakes, and so that's all fine. But did it make any difference? Oh, yes, it did. They had increased risk of being hospitalized, increased number of ED visits. I mean, it makes sense. Increased number of antibiotic prescriptions, increased number of steroid prescriptions, because the drug that they're supposed to be using, often as a modulator, wasn't getting down there. It just is another opportunity. If people are having asthma exacerbations or COPD exacerbations and they're back again and again, see if they're using their inhaler right. It's remarkable. And if they're having trouble and they just can't do it, get a spacer. Stick a spacer in there, takes that whole coordination bit out so they don't have to worry about coordinating their inhalation with the activation, et cetera. But it's a really good opportunity, again, for a teachable moment. Find out if they're an idiot, if they're using it as some sort of perfume, or if they're actually getting it down where it belongs.
Okay, abstract 31 is 2 days of dexamethasone versus 5 days of prednisone in the treatment of acute asthma and RCT. So we're sticking on the asthma theme here. And the backdrop to this paper is basically dexamethasone lasts a lot longer than prednisone. So we're typically seeing patients with asthma exacerbations and sending them home on somewhere between 3 and 5 days of prednisone. And they're sort of asking the question, would it be better to just give them 2 days of dexamethasone instead, which hangs around for a bit longer. So this is a double-blind randomized controlled trial where they randomized about 200 patients to get either 60 milligrams of prednisone a day for 5 days versus 16 milligrams of dexamethasone for 2 days, right? So this is sort of a huge difference in dosing, not just in terms of length of dosing, because 16 milligrams of dexamethasone is a ton of steroids. So they followed these patients out, and essentially they looked at a lot of different things like repeat ED visits and how long they stayed and how many times they needed to use their inhaler, et cetera, et cetera. And what they found was essentially no difference between either of the two groups. So what's the conclusion here? I'm not entirely sure, to be honest, because they didn't sort of get equivalent doses, I think, of steroids. I think that the take-home message, at least for me, is that if a patient comes in with an asthma exacerbation and you're giving them multiple rounds of therapy in the emergency department, you should send them home with some steroids. what the exact dose is, what the exact length of time is, which is the exact correct steroid. I don't know, but I'm not particularly sure that it matters either. That's sort of what I take home from this. I would say give them something is the message. Don't send them home with nothing.
Well, it seems to me that the history on this is that, decades ago it was a long steroid taper, and then it became less of a long steroid taper, then it became no taper, a short course, 5 days of prednisone kind of thing, and this is just an extension of that shows that probably very short bursts are about as effective as anything else. I mean, there's stuff in the peds literature with single dose.
Yeah.
So I think we're probably going to be getting down to a place where single dose or 1 or 2 days is probably adequate, which is probably not a big surprise given that every study that has tried to shorten the dose more and more has found that to be efficacious.
But I think that, I think people probably for the most part get that message. It's good you point, we don't do these, pred packs where they taper down over 3 weeks anymore for just about anything. How many people here are using 3 days as their sort of standard for asthmatic? About 4, 5? So
Yeah, I
most
think it's
people
sort
do
of
5.
Fives have it.
Right. Oh, I guess 5 is correct then. So those of you who are doing
We've
3 and
established the
4,
standard of care.
start doing 5. I think we just answered that
It's called
question.
evidence-based medicine.
Yeah, it's at its finest right there. So.
The only other thing I'd say about asthma, that since I think we're about to swing off of asthma, well, I got one more, is that when you have people that are presenting to the emergency department with asthma and you're giving them a pulse or whatever, I think we need to start considering putting them on more maintenance therapies for asthma. There's plenty of evidence now that a huge proportion of asthma therapy, both chronic and acute, occurs in the emergency department. And I think we need to start being part of that solution so we can stop seeing these patients and pulsing them so much and start using inhaled corticosteroids more frequently. I know it's a bit of a departure from what we like to do, but I mean, given the patients that we see, the resources they have, and our lack of wanting to see them suffer and or return to the emergency department with the same thing in 3 or 4 weeks, I think we need to start thinking about how we can incorporate ourselves into a more continuous treatment program for these asthmatics.
Yeah, particularly kids.
That's my soapbox, though.
I mean, kids, it takes out both the kid
Yeah.
and the parent. And it's the biggest reason kids miss school.
And there's
if kids
ample
miss school,
evidence that the primary
trickle
care
down is
doctor won't
forever.
do it.
Yeah.
And there's ample evidence their primary care doctor won't do it. We don't
Right.
know why. It might be they never go and say, oh, I was in the ER or whatever. But there's plenty of evidence to
Yeah.
that. Yes.
I was just wondering if you guys use like an asthma action plan in ER as well as sending them home.
So you,
Doing something like that
Yeah.
instead of for teaching.
So an asthma action plan, which has been used quite successfully in some of the children's hospitals across the country, particularly Pennsylvania has a great program. And what they do is basically teach, they use a spacer, they teach them about, they have the flow meter that says if it's this color, you do this, if it's this color, you do this, if it's green, it's all good, if it's yellow, add a steroid, if it's red, go to the ER. And they are able to keep kids out of the ER and school. And a big part of that is steroids at home. Early steroids at home is a big part of that. So they keep their Pred Forte in the fridge and they just give a dose when they hit the yellow zone. These kids do.
Yeah, and we do that in the pediatric section of our emergency department presently, although that we are in active plans to extend that to the adult side. It's trickier in adults. There's a lot of COPD and there's a lot of other stuff going on, so it's going to be more interesting to see how that interplay works out, but we're moving in that direction. We certainly do for peds.
I don't know that 33 has a huge amount of value here. It basically says if you have asthma and you give high flow oxygen, that it will raise their PCO2 a little bit. But I'm not sure what clinical significance it has. We're talking about when they gave this high flow oxygen, they got a PCO2 that went up to 45, and normally I guess in asthma your PCO2 is going to be 35. So is this bad or not? Probably not, but you don't need high flow anyway because, you can do much. There's just no reason to do that, especially if you have a finger thing on that tells you what their SAT is. And so I'm not quite sure what they're trying to get at in this paper, but maybe I could use some help.
Go ahead.
I just have actually a little bit of an unrelated question, but it's the peak flows. So I feel like everybody tells you to document the peak flow before and after, but often your asthma treatment is started before you've even seen the patient, and then the respiratory therapist will say to you, like, you're totally dumb for like asking for a peak flow for like the
It's a tough one because it's actually becoming more and more important of a measure, and it's now one of our quality measures for asthma that has been adopted. National Heart, Lung, and Blood Institute's been pushing this for a long time, both in the acute and the chronic setting to monitor somebody's asthma. And it's becoming now a measure that they're expecting us to do. And I think it's it's either Joint Commission or CMS, one of the two of them. It's now on their list of things that they're expecting us to do. And we will be checked for that. I think a lot of us didn't do it because we didn't see the utility in it for all of the reasons that you mentioned. People are often treated before we see them. We make clinical decisions on whether they can go home or not. The reason it's emphasized is that it turns out that patients aren't very good at gauging how sick they are when you compare to their peak flows on how they feel. And the sort of extension of that is that we aren't as good either at picking up how sick they are. That being said, we're not seeing a gazillion of these asthmatics bounce back every time we send them home. So I'm not sure where the problem lies, but the peak flow measurement is something that's sort of in all of these measurements of asthma. And I'm not sure how to integrate it into our practice, but it's going to be more and more emphasized, I think.
It was one of the recommendations in the Choosing Wisely's from yesterday that I kind of personally poo-pooed. Because I think a lot of times we decide that people are going to go home. They may not be as good as they're going to be, but we're about to load them with steroids, which we think is going to make them better than they are now over the next 6 to 8 or 10 hours kind of thing. And I do think that there is a big push now to people for patients who have chronic wheezing, where they're on medications every day. That why would we not put them on an inhaled steroid when they left? They are expensive, but it's considered to be the standard of care now to treat with these controller meds, and then when you need intermittent, albuterol, you shoot up with that stuff. But so that there needs to be a kind of a flip-flop, and I don't know that the community is necessarily into it, but I think the literature basically would say ER docs ought to give this stuff out if the patients aren't on it, and they meet the criteria of that they have daily wheezing.
Yes, in the back.
For pediatricians and primary care providers, that is one of the new CMS TRS guidelines that they are going to now be evaluating on. It's actually
Use of a modulator?
Inhaled corticosteroids
Yeah.
for chronic asthma patients. So that is something that CMS is now going to be auditing primary care.
And to be honest, I think that's probably quite legit because they have been so slow to get pulled onto this very well documented truck that says this works, and I'm not sure why. And maybe a cost thing. One of the sad things is that it is expensive, and it's not on anybody's drug formulary $4 list. It isn't, and it is the treatment of choice for modulating these people that have a lot of exacerbations. And it's unfortunate. It's expensive as all get out. Our patients, it's ridiculous.
I think this is one of those situations where the garden variety pediatrician is giving shots to the kid. And they're seeing the kid when they're well, and they said the mom said, it has the asthma. Oh, it's pretty good, and they don't realize that they had 2 ED visits, or in the past year. It's easy to miss that when you're dealing with you have a 5-minute visit, often with a mid-level provider, and you have 30 seconds with a doctor maybe, or something like that. So it's often easy to miss. Whereas our perspective is very different. Everybody we see is by definition poorly controlled. That is one of the definitions is an ED visit. Yeah. So, in our case, so we have a specific opportunity, and I would dare say responsibility to intervene at that moment. I dare say the responsibility because it is a little bit of a departure, but I think it's probably the right thing to do by our patients.
Number 34 basically says, an ABG doesn't tell you why someone is short of breath. That is not shocking to any of us in this room, and that it doesn't really help you at all. This basically took a bunch of people, a little over 500 people with just dyspnea, got ABGs in them, and looked at what their final diagnoses were, and did the ABG help you? And it makes total sense it didn't help you, no matter what those diagnoses ended up being. And the only thing that kind of filtered through is that if their pH was a little bit lower, they were more likely to be sicker, which I also don't think shocks you. So the reality of this is don't get an arterial blood gas. You don't need if you really care about the pH, get a venous blood gas. It is fine for the pH. If you really care, you can use a pulse ox to look at the oxygen. You can look at capnography to look at the CO2 if you really care. So ABGs really are rarely, if ever, indicated anymore at all. And this one is a paper that doesn't tell you should do them because it doesn't help in this paper.
Yeah, the only advantage in this paper is it's in critical care medicine as
Yeah,
opposed to an
that's true.
emergency department.
That's
I mean,
true.
this is like preaching to the converted, right? I mean, we all have not wanted to do ABGs for a really long time, and it's one of the favorite things for internal medicine resident or critical care specialist to ask us when you're assigning out a patient to
And
them.
trauma.
And
Trauma.
What's the ABG
Trauma.
show? And you're like, I
Crazy.
didn't do it. And they're like, you know, they sort of
Trauma
look at
loves
you like you
ABGs.
shot their
We
dog
had-
or something.
We had a trauma patient last night that I could not get them to get away from the wrist. This patient's
Yeah.
really sick. They need to be in the scanner,
Well,
not
if they
getting a
can't-
blood
if they
gas.
can't calculate that base excess. How are they gonna figure out if
Unbelievable.
they're
It's
sick
like,
or
get
not?
away.
So it's nice that this is at least in the critical care journal now, so that, you know, they're supposed to be reading this kind of literature too, and it echoes what we've been saying for a long time, that there's very little utility for this, if any.
So abstract number 35 is looking at oral contrast and the use of the diagnosis of appendicitis. So just so I have a sense of it, how many people here, their hospital or radiologist requires them to use oral contrast for patients rule out API? So still about a quarter of the room.
You know, this is crazy.
It is crazy.
I personally brought their literature.
They can't read.
You have to hide it in the car magazine.
Not comfortable.
Yeah.
Oh,
Yeah,
yes.
that's all they have to say, and where they
love it.
or they can say, in my experience.
Right.
Well, I
Yeah.
love all the thing.
I
Of
love
all
the
the
hedges.
reasons one might do something, physician comfort is like got to be the lowest, right? You know, I'm not
But-
comfortable.
No, but you do hear that a lot. They say like, well, that's how I'm used to it. I'm used to seeing the scans with oral contrast. So I feel like if I was to see one without, I wouldn't really know what I was looking at. I mean, this is just a study. It's a pretty big study, and it's one of many studies all saying the same thing. It's like 1,500 kids who got oral contrast, and half of them got oral contrast, half of them didn't. About 40% of them actually had a positive CT scan, so they had appendicitis. And what they found was that the ability to detect appendicitis was totally unaffected by whether or not they got oral contrast. In fact, like in a quarter of the kids, the oral contrast didn't even get down far enough as to where it potentially could be useful to detect the appendicitis. They had a lot of problems with the kids who got the fluids, the contrast, because they gave it via NG tube. So that's another issue. This paper for me is just it hones on a very important point, which is we don't need oral contrast to diagnose appendicitis on a CT. That's one really important point I think this paper proves relatively conclusively. The thing I've never understood about it is that, if you were to call a surgeon down to see a patient with appendicitis, CT-proven appendicitis, the surgeon walks in the room and that kid happens to be like taking a little sip of water out of a cup or something, it's
See you
like
tomorrow
all,
morning.
it's like all hell breaks loose, It's like, oh my
NPO.
God, we
Supposed to be
can't do
NPO.
surgery, there's supposed to be NPO, what are you doing? Oh, you got the contrast with 600 cc's of fluid? Perfect, like that's never sort of made sense to me, but I think this is a good opportunity, even though it's not really related to the study, to talk about the fact that for the most part, for kids, if you're diagnosing appendicitis, we should be using ultrasound anyways, as a first-line modality. And at our institution, if the ultrasound is negative or inconclusive and suspicion is still high enough, we either go to sort of an observation protocol or we actually do MRI on these kids instead of doing CT scan. So, question?
We don't use oral contrast anymore, but we still use IV contrast on every one of them. Are there any good studies showing that that you don't need that anymore?
Well, there was a study where they had, stop me if I mentioned this yesterday, where they had a large number of cancer patients who were just getting a routine scan of their abdomen. They weren't symptomatic, and half of them they gave IV contrast, and half of them they didn't. And one of the objects of the study was to see if you could visualize the appendix with or without the contrast, and whether one was better than the other, and there was no difference.
And there have been other studies looking at completely non-enhanced CTs, so no IV contrast, rectal contrast, and oral contrast versus either some combination of enhanced CTs, IV or oral or rectal or all three. And in general, there have even been meta-analyses of that literature. And in general, it showed that the accuracy rates are almost identical, usually in the neighborhood of total accuracy of 94% versus 95%.
Yeah, actually, there was a meta-analysis of 23 studies, and it concluded that the oral and non-oral and not using oral were comparable, but the truth of the matter is it was actually better if you didn't use contrast. So they were charitable by saying they were the same, but
I don't know, although I don't know anybody who isn't using contrast. That sort of hasn't yet been tackled unless you're
IV
doing
contrast.
IV contrast, unless you're doing the stone protocol.
I think it is. I think it
guys-
is ready. It's just not being adopted. You know,
Yeah.
it's like one of those things, like you say with your radiologist. It takes a little while to push things uphill.
But I,
sometimes.
you know, going back to the oral piece, this is one of those battles that's worth fighting. You know, it
Yes.
adds we have tons of literature now, tons of it showing the equivalence. We also have lots of literature showing that adding oral contrast adds a lot of time, delays diagnoses. There's lots of that literature out there. So they really can't stand on that leg. And now, you know, unfortunately, it becomes a political fight, not a legitimate, you know, sort of scientific fight. But I think it's one of those political fights it's probably worth doing.
No, I
it's going to
agree.
speed up the care of a lot of your patients. And then as soon as they adopt the new policy, within 4 months, they're going to have learned how to deal with it, and they're not going to ever say anything again. It's
Yeah.
just old habits dying hard.
The place I've just been for the last few years, it was a huge political fight, and the surgeons back to radiologists,
Yep.
because they're reading their own CTs as well, making their own decisions on surgery. But then the trump card that the radiologist would always pull, they would do it if we ordered it without contrast, and they would put a statement at the end. This is a
Right.
suboptimal study.
That's fine.
because-
You know what? I'm good with that. I mean, we all do that, right? You document preliminary read of your ankle x-ray. We'll see tomorrow if something's different when it gets over. We all have our hedge, so that's fine. I mean, if they want it, we know it's good enough. So, and they want to hedge it. So if God forbid they have that 1% that may get missed,
Well, they'll still be
Yeah.
on the hook because the literature says you're supposed to figure it out. I mean, it's right there. It's all over the place. So they can write that little hedge all they want. But if they write it's a negative study, I'm discharging. If they could put, but I really wish I could see better, and I wish I was a
Right.
better radiologist. and
yeah, I
all
wish
that
I had
kind of
a
stuff.
Mercedes.
You know,
Oh, I do have a
tough. That's
Mercedes.
too
Never
bad,
mind.
You know, and just for your.
Well, that's my job, right? Clinical correlation. That's what we do.
Right.
Yeah.
The only exception is a person with like zero body fat.
Yes.
In which case it's just impossible to say there's inflammation, even if he sees a thing.
This is
That's
United
an
States
area.
of America.
Yeah.
There is nobody here.
Let's cross that bridge when it comes up.
Yeah, never run into that situation.
And
but,
all of these things
you know,
are still generalities.
But again, I mean, now expanding it on beyond kids, if you really have an adult with 0% body fat, that's a good ultrasound candidate.
It is.
You know, so you got to be thinking about that as well, even in adults. So
And just to address your comment, just like the last paper was good because it was in critical care medicine, this one's in the surgical journal. So that's, you know, it's good to see it permeating all the different journals.
And I think once it gets to the point of, you know, if you look at the average age of our radiologist was probably 50, 55 to 60, and same thing with the surgeons.
Yeah.
They were late 40s, early 50s, and I think once people have been trained in places where they didn't
Sure.
do it, and then
That's right.
more and more people have trained, they can say, oh, wow.
Yeah, we have to nudge, yeah.
Right, and I think it's a lot of that.
Yeah. We have to nudge them along, but there is a sort of natural history to this too. Yes.
I practice up in Connecticut. I've been fighting this for over 10 years and will basically give it up at this point. Because this is what's transpired and I think this is what will happen. They say that the incidental findings are important for them. So when they don't see appendicitis, there's other things that they can pick up. They don't want to miss that, even though lots of literature against that. Number two, when Yale changes the way they do things, is when we will change the way we do things. So as long as the Mecca continues to do it,
And they're doing it that way?
and that's the way they're doing
I need
it.
to talk to those
But
people.
the only way I'm starting to get
Yell on the phone.
is with throughput.
Yeah.
Because
Yeah.
it takes
6 hours?
The minute you now
That's right.
put somebody into the channel for an abdominal,
Well, and now your administrators are going to care about throughput because they're getting dinged.
correct, and that's going to be time to reimburse.
Absolutely.
I think the future will be that will be the way that the
At your institution, yeah.
Or you could send the films out to India and let
No,
them
but there's
Get
the
another
whole
radiologist to
timing
read
of
them.
the oral, and it takes forever. All right. I see no further hands.
30
The impact of NG-tube lavage on outcomes in acute GI bleeding. This is in gastrointestinal endoscopy. This is a VA study from the West LA VA looking at 632 people hospitalized with upper GI bleed. They used some fancy stats to try to get two groups and match them, groups that got an NG tube, lavage kind of thing, and then those that didn't get an NG tube, and then they sought to see if there was any difference in clinical outcomes. I mean, I have not enjoyed putting NG tubes since I was a medical student because it's among the more painful, it's known to be among the more painful procedures that can be done to a human being. I was sort of taught that it would rarely change things, but I still had to do it. This is a study from the endoscopists, the very people who have been the biggest proponents of this, saying that it doesn't change any outcome of any relevance. There's no change in mortality. There's no change in the amount of blood lost. The only thing that they noted was that they did the endoscopy a little bit earlier if the person had gotten an NG tube lavage first. But I have no idea why that would be the case, and it certainly didn't change their total hospital length of stay, et cetera. So this is just more ammunition to say, or more argument to say that we shouldn't be doing NG tube lavages in upper GI bleeding, certainly not routinely, for most people. On occasion, there may be some really compelling argument, just like there might be a really compelling argument for someone for a CT with triple contrast, but the reflex should be to not put them on an NG tube, not to provide an NG tube lavage.
So we don't have a lot of time left, so you want to do a little picking and choosing?
Oh, yes. I like number 38. It's my other favorite. Quick and easy practice change for you to take home. This basically looks at treating nausea with Reglan, metoclopramide, and the difference in side effects, whether you do a bolus or a drip, and the efficacy difference, whether you do a bolus or a drip. And to cut to the chase, if you infuse it just mix it up in some saline and you infuse it over 15 minutes, your efficacy is the same at the same time, but your akathisia rates plummet. So a nice, fun, quick practice change is to go home and say, infuse metoclopramide over 15 minutes. Mix in your 10 milligrams and 50 cc's of saline, run it over 15 minutes. They'll get their nausea gone, and they won't get akathisia. It's kind of nice.
Yeah, if you can get your nurses to do it,
Yeah, well, there's that. There's the nurse thing, but that's separate. They don't do it. Our pharmacy does it. They just order it.
Mm-hmm. Takes too long.
Yeah.
That's right.
Yeah, ours isn't that long as far as waiting for pharmacy, but that is definitely a factor. So then you just have to deal with the side effect if it happens.
Maybe
which
they
is
could
not
just
infrequent actually.
pre-mix that stuff and just give it, 4 or 5 bags that in the morning you get for that day's use. It would seem, but that's probably too logical.
So then you get that moiety of the droperidol we talked about, where you distill it down to that get out of here little molecule and get them out.
There's a cluster of papers on adrenaline. Basically, I think they say that it might increase your ability to get to the hospital alive, but your ultimate survival is not increased. And I think there's one paper there that says your outcomes may be even worse from a neurologic point of view, which I think is, which one is that, 41?
That's 40.
It's all of them.
I
mean, it's definitely 39. This is where they took, it's a huge study of patients, and they were sort of supposed to be a randomized controlled trial where some of them got epi and some of them didn't in the field. But the truth is that a lot of the patients broke protocol. So they said, you know what, let's sort of re-look at our data and do a per protocol analysis instead of an intention to treat analysis. So we look at what they actually got. And then in this study, there was about 370 patients who got epi and 480 patients who didn't get epi. And what they found was that the patients who got epinephrine were more likely to survive to hospital admission, save, I guess, from the ED perspective, but they had much worse neurologic outcomes long term. They had much longer hospital stays, much more time in the ICU. I mean, basically what we did here is we artificially sort of kept people alive who should have been dead by all intents and purposes. So this article is not saying that epinephrine is bad. What they're actually saying is that a lot of times these paramedics broke protocol because probably these patients were really, really sick and they're about to die in the field. So they said, I'm just going to give them epinephrine regardless of what they were randomized to initially. So when they hit the door at the ED, this is probably a much sicker group of patients. So even though their conclusion is that the epinephrine group did worse, it probably is because they were in way worse shape to start out with, which is why they got the epinephrine in the first place.
Yeah, there's a couple other studies here, huge registry from Japan showing the same findings. People who got epi had a higher rate of return of spontaneous circulation and a lower survival and a lower good neuro outcome survival. It seems to be pretty consistent that you can resurrect someone for a few days and maybe even get them resurrected to the level of a cucumber. But other than that, epinephrine isn't doing a whole heck of a lot. I think someone should comment on one of the papers on the diagnostic and prognostic utility of high sensitivity.
Yes, number 42. How many of you have high sensitivity troponins available to you? My heart goes out to you, because what it buys us is a whole lot more mess and not a lot more help. What these highly sensitive troponins do is basically they're anywhere between 1,000 and 10,000 times more sensitive than our standard troponin. And one thing that happened in Canada was they got transitioned to, in one particular hospital, Jim Ducharme, who works on our panel, said in his hospital group, they got transitioned without knowing it. And all of a sudden, all these people were ruling in. Because there's a lot of false positives, and anything that gets that sensitive, you basically lose specificity. So lots of things can cause you to have a little bit of a troponin, and now you're getting all these non-specific findings. And what abstract number 42 says is it emphasizes to me the only thing you may get out of a highly sensitive troponin, which is if someone is an N-STEMI, the real deal, not a false positive, but a real deal, you will diagnose that earlier with these high sensitivity troponins. It doesn't, though, give you the ability to say, oh, you're low risk, your first one's negative, you can go home now. Because the dynamic of troponin is still the pharmacokinetics of troponin is still what it is. It will peak at 8 to 12 hours, and even then, its overall sensitivity in and of itself isn't fabulous, 80%, 85%. So we're taking a test that is making our lives miserable. And a lot of cardiologists now, I don't know if you guys have dealt with this, but I was talking to somebody who said their cardiologists are saying, don't call me with the first one. I know there's a lot of false positives. Give me a trend before you call me back. I don't want to hear about it on the first one.
So give them the trend an hour earlier. It's so great.
Yeah, exactly. It's just wacky. I think this is a big problem, and all it really buys you is perhaps the ability to rule in the N-STEMI a little earlier with the payback of there are going to be some false positives in there, a significant proportion of false positives now, which is the next paper that talks about that false positive rate. So this new thing is not so great, and it does not. Don't let anybody tell you it gives you a safe way to send somebody out early. It doesn't. It doesn't.
Any others, gentlemen?
I think we're all right.
37 basically says nothing works for soft food for food bowls
impaction.
except for
Endoscopy.
gassy liquids.
Cerveza.
Fizzy
Gassy
drinks.
liquids, fizzy drinks.
Cerveza.
And things like glucagon, which we thought worked, or according to them, they couldn't prove that was the case. Benzos, no effect there. No studies on opiates. I think a lot of people get a little shot of something to calm them down a little bit. Maybe I used to do that. One of the most important things in this paper is when endoscopy was done, 55 to 90% of cases have been reported to have some kind of underlying pathology. So that's kind of the message here, is that if you had some chicken stuck in your gullet, that you really ought to have somebody look in your throat,
Gullet.
even if you pass it. Gullet, yes, you heard the term gullet. And I always mention that the fizzy drink that I prefer personally is Dr. Pepper, because it's a medical medical drink.
Our patients literally ask for cerveza. They just want to chug a bit of beer.
But that has nothing to do with
It has nothing to do with
impaction.
sending food stuck in
That's
there.
just LA County. Yeah. All right.
All right, I think we're
Let's
good.
break. Yep.